And of course you can give textures. So let me show how I give textures. For example, yeah, I place the veneer. Now on the veneer I mark my textures. So I mark developmental depression, perichymata. Mark them and then use your round burr at a slow speed and give those depressions and textures what you have marked. On the semi-direct veneer, you will do the same thing on the direct veneer. You will not do on the ceramic veneer, but you will communicate to the technician to do this on your veneer. Okay? Once you do this, you polish it. And once I polish, I get very good effect. Okay? This was the case done by Dr. Stefan Lampel, who is the CEO of Edelweiss Dentistry, Austria. We need to thank him for giving the system here for the workshop today. And this is a 9-year recall. I think he's a football player. And you see the kind of diastema he has. And this is the way he closed the diastemas and spacing with these veneers. So, okay. And this is the 9-year recall. The patient is like this after 9 years. So there is a little bit of wear on the surface, but otherwise there's absolutely no chipping, no staining, no debonding of veneers. So Dr. Dieter Dieschi from University of Geneva has worked a lot on this system. You will find a lot of publications and literature of this system, also a lot of follow-ups. Okay? And this is how it is after 9 years now. You could see a little bit of dullness on the surface. You could see there on the lateral, but absolutely no debonding. You can see a little bit of dullness, wear a little bit on the surface. Otherwise, doing pretty good. Okay. You could also characterize them. You could also characterize them from inside. You could also add translucency. I will show all this in the demonstration. Then all of you will do that veneer. So you are free. You can do one veneer. You can do two here. Or you can do one, take the system back with you today, and you can try it out on a different day. So it's up to you. So you have two veneers with you. You have one occlusal veneer. So let me show you how occlusal veneers are working. So these are the occlusal veneers. Okay? These are only 1.6 millimeters in height. It's like a tabletop. I don't know how many of you do tabletop or overlays. These are all ready-made. Huh? You get ready-made of different sizes. So it's available from small, medium, large. And it's also available as extra small if you're doing on kids. They also have pediatric crowns.
Prefabricated veneers.
Yeah, prefabricated. They have pedo crowns as well, because you have on pedo crown market, you have stainless steel, you have zirconia, but you have nothing in between, and they have composite crowns. Stainless steel, not many kids will like it. Zirconia, I feel it's too rigid for the kids because the modulus of elasticity is too high. It would directly affect their temporomandibular joint. So I would not recommend a zirconia.
Large brick 130.
Pardon?
130. Large brick.
Okay. So composite, the rigidity is very close to dentine. It's around 18 to 20 GPa, whereas with zirconia is 100 to 120 GPa. So always use what is best for the nature. Okay, how you can simulate. So we select the size. They will also have sizing guides. So what you will get in the kits today is you will get sizing guide, which is very expensive. So that is for you, and it is autoclavable. You can keep it with you whenever you want to buy. You will first check the size in the patients. Okay, it is available as single refill. It's available as set of 6, set of 8, and the full kit. So it's up to you. I would advise always buy refills or a small intro kit to start with. Get acclimatized with this system, because with anything new, any new concept, anything new, please remember it takes a little bit of time to get hold of it. Don't assume that today you do the workshop, tomorrow you start placing veneer right, left, center. No. First 2-3 cases you will learn. You will learn how the placement is, how to modify the shape, how to get to the right proximals. So after 3-4 cases you will get hold of the system. Okay. So once I select the size, it's everything the same. I prepare the tooth, I prepare the veneer, etch and bond the tooth, apply veneer bond on the veneer, take my composite, lute it. Okay. When you place this, all the excess will come out to that around the interface, and then finish and polish. So this is the kind of result you get. And you can do a lot of full mouth cases. See cases like this, a lot of wear facets, attrition. You don't need any preparation. Just roughen with diamond or air particle abrasion, and then place your tabletops. Okay, place your tabletops. So from here you reach here. Of course, check the occlusion as we already discussed with two different papers, 200 microns and 40.
How we will maintain vertical height during this?
You have to establish the vertical height. If you are doing full mouth rehab, then it has to be with faceboard transfer, articulation. So you already have this. So you can give this to your laboratory. They will adjust and give it to you. But if you yourself are doing, you can also adjust in your lab. Okay. So you have to take the bite first with the right VD and then transfer that into the articulator with this. So for example, if you have a case like this, now the advantage with this system is you can use them as a transient restoration. What do you mean by transient restoration? For example, you want to delay the implant in this case, okay? Or for some reason you are not able to do implant because there is not enough bone. Prognosis is very poor. So what choice you have? And at the same time, the other two teeth are not periodontally sound. So you can't even do a bridge, okay? Because you know if I do a bridge, it will fail. So I will do a Maryland, okay? Or I will do a fiber reinforced composite. So if I have to do a fiber reinforced composite, it's very simple. You have to make two slots on the proximals of both the tooth. The slot has to be in the middle third of the tooth, okay? Not too high occlusally, not too down gingivally. So I'm going to make a slot. I'm going to etch and bond the slot. I'm going to place a thin layer of flowable on both the sides of the tooth, and I'm going to place my fiber horizontally. Now when you place your fiber horizontally, the fiber should not be straight. It should be like, like a curve, like a U. So it takes up the load. Now why like a U? So I have enough space here, I have enough space here. Okay? So my forces are distributed evenly. Once I place the fiber, now what I do is I have my overlay already ready. The top part now is already ready for me. It's prefabricated. What I have to build is the bottom part. So I take a mylar strip, put your mylar strip on the ridge so that there is some separation between the ridge and your composite. And I build my base of my composite with my direct composite. I cure it, and then as I come on the top, I place my overlay and I finish and polish. So this is one way of doing this directly in the mouth. There is another way. What I do usually, because I need control. I don't like patient's saliva, tongue. It's not easy to do in the mouth. Let me be honest. So what I do is, after preparing the slots, I take a quick triple tray impression. Okay, I pour the model and I do all this on the model. I am free, I can do it in half an hour. It's so easy, there's no disturbance. Once I finish, and I can finish and polish also well, my Pontic. Okay, once I do that, I call the patient and I cement it. That's it. So it's easy. Otherwise, patient has to sit for 30 to 45 minutes chair side. It's not easy, and you will not be very precise. Trust me. The finishing will not be very good if you do direct, but you can do indirect as well. Okay. So let's look at these cases now. Let's talk about indirects. How many of you are doing indirect restorations? Overlay. Everybody is doing a crown. All endodontically treated teeth, you are placing a crown. No. Why? No, posterior I'm talking about.
Posterior almost some
All endo we place a crown, right?
Yes.
Patient knows even before you finish the endo that you are going to place a crown.
Yes.
Ridiculous.
They want.
How can you decide the restorative treatment plan even before completing endodontics? Patient comes to you with pain, there's a lot of decay. First of all, I'm not very sure whether I'll be able to do endo or not. I will tell my patient that I will do endo only after I excavate all the decay, correct? What's the first principle of endodontic treatment? You first remove all the decay. Once you remove all the decay, that is when you know how much of tooth structure is remaining. Sometimes there is so much of decay that as you start removing decay, at one point you'll come to a stage where there's nothing now. And now you have to tell the patient I have to extract the tooth and do an implant. So please have clarity. You will tell patient that I will do endo only after I excavate decay. After I do my endo, I will tell my patient that what type of restoration I will do. So now what is important? How do you decide when to do direct and when to do indirect? Anybody? Mm-hmm. So let's look at this. Yeah. You are dealing with two scenarios. One is vital, no endodontics done, and the other is non-vital, where you have done endo. Now we all know from literature and scientific reviews available that there is not much of a difference between a vital and a non-vital tooth in terms of strength, in terms of hardness, and in terms of moisture loss. But the difference becomes more evident when the remaining dentine is quite less. Are you understanding? For example, if I compare this tooth with this, what is the difference? The difference is only it is endodontically treated, that's all. The rest all remains the same. Are you getting my point?
Yeah.
Meaning to say, I have good walls, all four walls, no wall missing, all are present, and I have good thickness of each wall. Same thing applies here. So will I do a crown here now, in this case, after endo? No, you will not. Absolutely, you will lose all that. The logic is, whatever is remaining of this, you will lose half of it. Of this, you will lose everything of this. Then everything is on the core now, it's not on the tooth. So ultimately what will happen? Nothing happens to your zirconia crown. After 3 to 5 years,
cervical
tooth will
fracture. Fracture, cervical.
because now this tooth is not supported by sound dentine. Please remember, dentine is the structural dampening core. Dentine as a structure is so very critical because it takes up a lot of stresses. And in any case you lose this dentine, then the tooth will not survive. But say for example, I'm looking at this tooth and I'm looking at this tooth now. Now the difference is significant because I have 2 walls missing, 2 walls remaining, and plus it is endodontically treated. So here I can still get away with a direct composite, but here I will not do direct, I will do indirect, but I will not do a crown. Why? Because I want to retain these 2 walls and strengthen these 2 walls with my overlay. Is it very clear? So please be very rational about your case selection. Read the substrate. What you have to read is very simple. Read the size of the cavity, thickness of the remaining walls, position of the cervical margins, presence of cracks, position of tooth. These are some things which you evaluate before finalizing your treatment plan. Is it very clear? Let me show you. Now let's see here. What will you do here? So what all you should see? Size of the cavity, very big. How many walls remaining? All walls remaining. Thickness of the remaining walls, very thin. Correct? How much it should be at the base of the cusp? How do you measure? How many of you have a gauge like this? Let me show you. This one. Please buy that. You can get from any dental dealer.
Yes.
But you go at the base of the cusp. Base here. Not here. Don't measure at the tip of the cusp. That's wrong. Because which dentine is supporting this tooth? Here, this dentine, not this. Here what you're measuring is enamel. I need the dentine. So at the base of the cusp, a minimum thickness I require for a non-vital tooth is 3 millimeters. For a vital tooth, it is 2 millimeters. If it is 3 millimeters and above, I can do direct composites. If it is 3 millimeters and below, I will do indirect restoration. Is it very clear? Okay. This is called analysis of cavity factors. You analyze the factors of the cavity. So let's see here. Evaluate what is missing. Interaxial dentine, ridges, roof of the pulp chamber. For me, these 2 things are very important. My interaxial dentine, that is my pericervical dentine, and marginal ridge. If I lose 1, 2 ridges, it's a little critical. If I have both the marginal ridges, that's a beautiful situation for me. Okay? Occlusal overload, hard tissue cracks. The moment you know that your patient has heavy occlusal loads and that particular tooth has a crack running, you can't do direct. These two, if they are present, you have to do indirect. Is it very clear? Okay. So please read this. For vital tooth less than 2 millimeter, you have to do cuspal coverage. More than 2 millimeters, no cuspal coverage. Is it very clear? For vital tooth. Okay. For non-vital tooth, it is 3 millimeters. If it is less than 3 millimeters, I will cover the cusps. It's more than 3 millimeters, I will not. So this is how you decide whether you do direct restoration or indirect restoration. So it is structure versus substrate. So please read this, okay? See, these are all the cases where you will do indirect. There is always a confusion. Okay, but again, read the substrate, read what is remaining, read what is missing, and out of that remaining, what is the thickness remaining. That is what you need to see. Okay, is it very clear? Okay.